Alrighty guys, so this is going to be your presentation on the genitourinary and reproductive system. The title slide is not on here because I had to get rid of something. It was too large. So this is the first slide we're going to do. These are some terms that you hopefully remember from 5th semester. Take a moment and see if you can recall what they mean and think about what type of patients you might see with these symptoms. So if you put that dysuria is painful urination, you are correct. Patients with UTIs might have dysuria, painful urination. If we are treating it, then we're not too concerned about it. But if it's a new symptom, then we'll want to do some further assessment. Side note, we usually give a drug called pyridium for dysuria. It doesn't help at all with a UTI. It doesn't help with the infection at all. It only helps with that pain. But it's really important that the patient knows this changes the color of their urine. Usually it's like an orange-red color. So that would be part of your patient education if you were to see this drug on a pharm test or med-surg test. With hematuria, if you remember, it is blood in the urine. Blood in the urine could be seen also with a UTI. It could be seen after some kind of procedure or examination. In the urethra, pink tinged urine is expected after a TURP, which is a procedure to relieve some of the prostate pressure on the urethra. One of the big things that comes up a lot is bright red blood, lots of blood or clots in the urine. That's never something that we can just watch and wait. Usually we need to do something about that. So pink tinged urine might be a symptom of a UTI, might be after a TURP, might be after a lithotripsy to get rid of a kidney stone. But if it's bright red blood, that's going to need more urgent attention. Polyuria is excessive urination. So if you recall, this is a symptom of diabetes. Your body is trying so hard to get rid of all the extra glucose that it's making you pee a lot, and that's what this means, peeing a lot, going to the bathroom a lot. Nocturia would be excessive urination at night, so it could be normal to get up once in the evening, at night when you're sleeping, but if you're getting up all the time, that would be considered nocturia, and it would be a symptom of something else going on that we may need to treat. There's some other terms that you're going to need to know, but we'll talk about them as we go along. These terms are the ones that we wanted to bring up at the beginning because they should be coming with you from 5th semester. So now we've got some lab studies, and for my students, if you remember the values that I had told you prior, that's fine. Just you can keep remembering those ones. These ones are going to be a little bit different. They are from your textbook. When you get to the NCLEX after you graduate, they will be giving you the normal ranges, but while you're here at Arizona College, you'll have to memorize them. But if you remember the ones in the book or the ones that I gave you, they're close enough that they will both work for the purposes of your test. And so I don't want you to fret if you're like thinking that these are not the same. So we've got these values that are going to tell us something about the kidney. So what does each test look at? Your BUN is going to measure how well the kidneys are excreting urea nitrogen, which is a waste product. The kidney's ability to excrete urea nitrogen, which is the UN part. The B is blood urea nitrogen. And according to your text, we're going to say the normal value is 8 to 21 milligrams per deciliter. And for my students, I think I told you guys 10 to 20. To me, that's a little bit easier to memorize, but 8 to 21 is also considered correct wherever you look. They're close enough. You may want to think about when would this value be high? When would it be low? Situations when you might see an elevated BUN could be because your kidneys are not functioning properly. Could also be with liver disease. Dehydration is one of the big ones. Infection, consuming a high protein diet, GI bleeding, using steroids, and possibly trauma to the kidneys. Low BUN could result from severe liver damage, could be malnutrition, consuming a low protein diet, or fluid volume excess, so too much fluid. With your creatinine, this is your most reliable indicator of kidney function. So most, that's an important word, most reliable indicator of kidney function. And I believe I told my students 0.7 to 1.4. According to your text, it's 0.5 to 1.2. Either one will work for testing purposes. So with your creatinine, this can be elevated in a number of situations, but one of the big ones is if your renal system is impaired, and we need to look into this immediately. So with your BUN, if that's elevated, maybe they have dehydration, and we're not gonna need to address it as urgently, but creatinine being elevated, we need to quickly take action before more damage occurs. So could be because there is acute or chronic injury, could possibly be elevated because of cancer, diabetic nephropathy, could be shock, could be congestive heart failure, or could be because you're consuming a high protein diet. When we say high protein diet, we mean it's higher than your body can process. If somebody's just eating a lot of protein and your body can handle it, it's not going to elevate your creatinine. But if it's an excessive amount of protein that your body doesn't need to use, that's a time you may see this elevated creatinine. If the creatinine is low, it could be because of a muscle mass problem, certain medications such as aminoglycosides and cephalosporins, or the use of lithium carbonate. Your BUN / creatinine ratio, this is something you probably won't see a whole lot, but basically just showing you a ratio of the two values. And so that should be between 10 to 1 to 20 to 1. With the urinalysis, this is an overall examination of the urine. It looks at white blood cells, it looks if there's blood in the urine, protein in the urine, glucose in the urine, but the only value that you'll want to pay attention to memorize would be the specific gravity. So 1.005 to 1.030. This is the specific gravity. So the specific gravity would be higher the more concentrated your urine is. So if you're going this direction, that means that your urine is very concentrated, and that could also indicate dehydration with high specific gravity. And the opposite, if your specific gravity is low, that could be a fluid excess. Okay, so we have some exams of your GU and reproductive system. What do you need to know about these exams? So with a breast exam, there are, you can do a self-breast exam. The woman can examine her own breast, but when she's doing her well woman checkup or seeing the doctor for a concern, they will do the breast exam and have you lie flat on your back, which is supine. And if they are examining the right breast, or while they are examining the right breast, you put your right arm behind your head. While they're examining the left breast, they would put their left arm behind their head. With a mammogram, this is where they put the breast between two plates, and it is a radiologic exam, so radiation, you'd have to make sure the patient is not pregnant, and then they look for any abnormalities like tumors, densities, and see if there's any signs of something abnormal within both breasts. A breast self-exam, so this is what the woman performs on herself, either up and down or in a circular motion. So if we have the breast here, you can go in an up and down fashion of palpating the breast, or you can go around in circles from starting the inside all the way out. My drawing didn't quite look the way I wanted it to. This one should have been more circular. The point is that you do not want to miss anything. So you'll go start in the middle and work your way out. After the shower is good, and not while you are menstruating. The breast can be very tender during that time, and they can feel different during menstruation. And so you will want to do it not while you're not on your menses, and in front of the mirror to also inspect for any abnormalities visually. With a testicular self-exam, they recommend that is done once a month, and you'll palpate the testicles for any hard nodules, anything that may feel abnormal. This is definitely recommended after the shower when the testicles are kind of soft and supple from the warm water. And you should be able to palpate the vas deferens, but there shouldn't be anything really rock hard. That would be a concern. All right, so there actually are a lot of changes of the GU and reproductive system as we age. So you'll want to take some notes. I'll write down the ones that I have and hopefully can fit them all. So with your older adults, the blood flow to the kidneys decreases. It's supposed to be an arrow, decreases. We'll have a decreased ability to concentrate urine. There's vaginal changes that put them at a higher risk for UTIs. And the pubic hair thins. This is not the end of the list, but I'm running out of space, so 1 second. So go ahead and write these down, and then I will, I think I can fit it up here on the picture. Your testicles become smaller and softer. And then there's atrophy of the penis. I apologize, I have a cough and I'm trying to suppress it right now. And then you will have your, the scrotal sac will lose elasticity. Loses elasticity. So these are some of the main things that you will see in our older adults. Alrighty, so now looking at these diagnostic procedures, we have a laparoscopy. So this visualizes the reproductive system, the female reproductive system, because we're looking inside the abdomen, the abdominal cavity. They will put some scopes into the abdomen, and they will instill carbon dioxide gas. So what this gas does is it expands the abdomen to help them see all of the parts. However, when they put this gas in, it needs to go out. And so after this laparoscopy procedure, the patient may have shoulder pain or abdominal pain related to this CO2 in their body. And so the best way to get rid of it is just early ambulation. They need to get up and start walking. But before we get to that point, we have to do the procedure. So they're looking for anything going on with the female reproductive system. One of the big uses is for ectopic pregnancies. And maybe pelvic inflammatory disease or abscesses. So it can be used to diagnose these things and then also to remove them. They could look for uterine fibroids, ovarian cysts, possibly identify causes for amenorrhea, which is having no period at all, no menses. And infertility, as well as endometriosis. Patient education, we definitely want to, before they do this procedure, because it is considered a surgical procedure, they need to discontinue any anticoagulants, aspirin, NSAIDs prior to the procedure, usually a week. If the patient is on a beta blocker, then you actually do take that as ordered. That's one thing to know. So when you have these kind of procedures, they're usually NPO the night before, usually at midnight the night before, but they will let you take your beta blocker with a sip of water, usually that morning, right before the procedure. Alright, so now another diagnostic procedure would be our ultrasound. Many of you are probably very familiar with abdominal ultrasounds. You can also do ultrasounds of the breast, the pelvis, the prostate, scrotum, thyroid, and parathyroid glands. It can be used to diagnose aneurysms, cancers, infections, fluid collections, masses, and obstructions. The patient education would be, do not allow the patient to eat or drink until the gag reflex has returned due to aspiration risk. So this may not be for all of the patients, depending on the type of ultrasound they've had, but really any procedure that might affect the gag reflex. This would probably be more if they were doing the thyroid or parathyroid, I'm guessing, but this is part of the education on here. We did talk about this with our bronchoscopy, because they're putting that scope down the throat. Returned due to aspiration risk. Alrighty, so now we have our colposcopy. This is a procedure to visualize and assess the cervix and vagina related to suspected cancer or other disease. So this is done after we've had an abnormal pap smear. So this is a little more invasive. and more specific. So after you get an abnormal pap smear, it's saying, okay, there's some abnormal cells, and we got to figure out what exactly is it. Some other uses could be something called cervical erosion. Could be because of infection suspected or inflammation. A papilloma. But the big one that I have seen come up again and again is doing this procedure after an abnormal pap smear. So important education: do not insert anything into the vagina 24 to 48 hours prior to this procedure. Or also 24 hours after the procedure. And you will expect some bleeding after this colposcopy, but excessive bleeding would be something to report. We want them to avoid strenuous exercise after the procedure for about 24 hours. Avoid strenuous exercise. If the patient is on their period for the time that they're supposed to get this procedure, we would need to reschedule, because the whole point is to look at the cervix and the vagina, and with active bleeding going on, we wouldn't be able to do that. So reschedule if on menstrual cycle. Menses. And then we definitely want them to void beforehand, so empty their bladder beforehand. Which was something I didn't mention on the ultrasound. With an abdominal ultrasound, sometimes they actually want you to keep your bladder full, because it makes it easier to determine the difference between the bladder and the uterus. But with the colposcopy, definitely empty your bladder beforehand. Okay, so now some disease processes. We're going to start with breast cancer, which many of us are probably very familiar with. This is cancer of the breast tissue. The nurse's goal for metastatic cancer, this would be to basically offer support for the patient, manage the client's anxiety, depression, and pain. The big thing too is if the patient is very optimistic, we want to support them in that. So they want to do everything they can to, to try to have the best outcome. We work with them on that, even if the chances, we know their chances are very small. We will support their optimism. That's a very important thing to do. We want to do what we can to minimize any complications. They may need surgery as a form of treatment. We can do just a tumor removal or a lump removal, a lumpectomy, or they may need a full mastectomy where they get rid of the full breast, or bilateral mastectomy, both breasts. Remember, if they've had a breast removed because of a mastectomy, you will not use that arm on that side. So if the left breast was removed, we don't use the left arm for blood pressures, IVs, blood draws. They may also do chemo and or radiation. They're going to need pain control, pain medications, antiemetics, because they will feel nauseous. We want to make sure to keep that at bay as much as we can. And then coughing and deep breathing. Because if they're having pain, in their breast area, they may not want to expand their chest, but we need them to keep those lungs inflated and keep any junk out of them. So coughing and deep breathing will help they don't develop a pneumonia or an additional problem on top of what they're already dealing with. Okay, so now moving on to endometriosis. So what is endometriosis? This is when our uterine glands exist and they grow outside of the uterine cavity, and it can be very, very painful. So endometrial glands exist and grow outside the uterine cavity. So it depends on, let me write this here. It results in pain. It's very painful. Pain and sometimes infertility. So this is all part of what is this? I kind of wrote into the treatment area. It depends on how severe it is for the patient, but some of the treatments are going to be oral contraceptives. The laparoscopy we talked about earlier. Hysterectomy in extreme cases. This would not be our go-to in the beginning. And then they may need their ovaries removed. And just like with the breast cancer, this is going to require a lot of emotional support for the woman. Whether they're not going to do any of these treatments and just do some pain control for a while, or if they are going to need, an extreme solution like a hysterectomy, it's going to be affecting them in a lot of ways, especially if it's impacting their, if they have a strong desire to have a family and they're not able to get pregnant. That can be very challenging. Okay, so dysmenorrhea. Let's think back to our very first slide where we had dysuria. So this same prefix, the dys, it refers to the same word we used back then. So take just a moment and think about what this might mean. So if you guessed painful menstruation, that is correct. So these are painful periods. Often it's experienced with like severe cramping. This can happen to really anybody, but a lot of times it will happen in the beginning when girls first start their period and then gets better as they get older. However, I will say that I know for some people it doesn't get better, and there is just always a lot of pain with their periods. The cause is because of a buildup of fatty acids. In the cell membranes after ovulation. So this may not mean a lot to you, and that's okay. Just know that this buildup of fatty acids causes a lot of pain, and it occurs after ovulation. So the treatment can just be, symptom management and NSAIDs to help with that pain. They may need oral contraceptives as well. Sometimes IUDs are used. There's some herbal preparations. We don't need to know the specific ones right now. You're welcome to look those up if you would like. Heat therapy. I'm sure some of you have seen, you just put a heating pack on your abdomen and that can help. Exercise. So sometimes whenever you're having cramps, usually the last thing you want to do is exercise, but it has been shown to help. And then the last one on the list is some omega-3 fatty acids. So the omega-3 fatty acids, these are the good fatty acids that help with the buildup of these fatty acids that are causing pain. So you can look at this list over here. It's kind of hard to see, but there's some things that have, they're rich in omega-3. So flax seeds, walnuts, sardines, salmon, soybeans, halibut, scallops, shrimp, tofu, and tuna. Okay, and that was our last slide for this part. So I'll be doing the next one. Let me pull that up here. wasn't. Oh no, it wasn't. Okay. I think there's a couple more. So fibroids. This picture looks pretty bad to me. But the thing about fibroids is they are not cancerous. They are benign tumors. So benign means not cancerous. In the pelvis. And they are the leading cause of hysterectomies. The way that we treat it, we can do hormone therapy. That can sometimes help shrink it. There is something called tranexamic acid, and you may have never heard of this, and that's okay, but you may want to remember it now. Tranexamic acid, that is one form of treatment for fibroids. They may also give them gonadotropin releasing hormone. And then if they need to, they may also do surgery, like in the picture where they just need to take the whole thing out. Take the fibroid out, or they may do a whole hysterectomy. This gonadotropic releasing hormone is abbreviated like this in case you see it. So they're not cancerous, but they still can obviously cause problems, especially if they're as big as this one. All right, so looking at ovarian cancer, this is cancer in the ovaries, so cells of the body that grow uncontrollably in the ovaries. How are we going to treat it? We can either do surgery or chemotherapy. That's pretty much it to know about this. The only thing also is that if we remove the ovaries, then we're going to need to probably have the patient on some kind of hormone therapy after, because your ovaries are regulating your, your estrogen balance, and so if we remove them, they may need to be on estrogen or progesterone after the surgery. Alrighty, cervical cancer. So again, we've got cancer cells of the cervix. How do we diagnose this? So you want to do a pap smear by age 21. And then if it's normal, every 3 years after. If it's abnormal, which procedure are we going to follow up with? Who remembers? If you said a colposcopy, that is correct. So an abnormal pap smear would result in going back in and doing a colposcopy. This is, again, I think we mentioned it, you want to have the patient empty their bladder before that colposcopy. Nothing in the vagina 24 hours before the procedure, but also 24 to 48 hours after the procedure. If they're on their period, we want to reschedule the colposcopy. How are we going to treat cervical cancer? Surgery, possibly, and chemo and radiation. Okay, so I'm going to switch over now to our kidneys. We'll go back to the reproductive system a little bit towards the end, but now we're going to go into our urinary system. So urolithiasis, I just want you guys to know, if you see the word lith or lithiasis, that means stones. So this is specifically talking about kidney stones. So what's happening, or they call it calculi. Calculi is plural, calculus. So you might hear the term renal calculi, renal calculus. Layman's terms is kidney stones. There's microscopic crystals that are building up in the urinary tract. So in the urinary tract, it could be here in the kidney itself, it could be in the ureter, or in the bladder. If we do not remove them, what do you think could happen to the patient? If we just leave these stones in here, what kinds of things might happen? So just take a minute and think about that. One of the big complications is going to be urosepsis. So remember we talked about sepsis, a infection of the whole body, and you'll see their blood pressure go down and their heart rate go up. So urosepsis is becoming septic because of a urinary problem. Something is called pyelonephritis. This is an infection of the kidneys themselves. You do want to know this term. This is something I would put on your vocab list. Or there could be an obstruction of urine flow. So how are we going to treat it? Well, there's a possibility of just passing the stone by yourself. If you are taking care of a patient who has kidney stones, we have to strain all the urine. So strain all urine. We're going to also teach them certain foods to avoid that can lead to kidney stones. One of them is oxalate, and calcium, depending on what type of stone they had. They need to drink a lot of water. Oh, so I'm going into education right now. Hold on. Let me not get too far ahead. So if they've developed a complication like sepsis or pyelonephritis, our treatment's going to include antibiotics. If there's too much of an obstruction, they could possibly need a nephrostomy tube. Let's see, where can I write a I'll put this down here. Nephrostomy tube may be necessary. So with some of them, we may have to go in and surgically remove them. There's also a procedure called a lithotripsy. So lithotripsy, which it may be coming up on another slide. Let me look ahead real quick. Lithotripsy. No, I don't see it. Okay. Okay, so lithotripsy, remember the lith part means stones. Lithotripsy, it's where they actually send either high pressure water or these shock waves through the water is what I should say, while you're laying on the table, and it hits your body with the pressure to break up the stones. So there's nothing invasive about it. But it's sending these waves. It's called, something shockwave therapy. The shock waves will hit the back, hit your back where your kidneys are located or wherever the stone is, break it up into smaller pieces, and then your body is able to pass it. So after a lithotripsy, you definitely want to be straining all their urine. There is a possibility for one of those pieces that got broken off to get lodged in the urethra. So we also want to be monitoring their urine output. Let's see. We want to aim for 2 liters of urine output. That's our goal, to make sure that they're flushing everything out. Strain all the urine. We want to make sure education would be, to drink fluids, increase fluids so they don't get more kidney stones. They do want to avoid nuts and coffee and things containing oxalate. Right now, I cannot tell you what contains oxalate, so you don't need to know it, but if you'd like to look it up, feel free. Sometimes a low sodium diet might be needed because sodium can lead to dehydration, and dehydration can lead to kidney stones. Oh, here it is. I knew there were some things. These are foods that contain oxalate. Rhubarb, chocolate, tea, coffee, and nuts. So your patient cannot tell you, oh, I'm drinking a lot of fluids, I'm drinking coffee and tea. That's not going to help them. Chocolate, tea, coffee, and nuts. Okay, I think I filled this slide up plenty, and we can move on to the next one. All right, so benign, it should say benign prostatic hyperplasia. It looks like it got hidden behind the image. So benign prostatic hyperplasia, this is an enlarged prostate. And the word benign indicates that it is not cancerous. So the causes are hormonal imbalances in the male. It actually is a imbalance between estrogen and testosterone. So the symptoms, you will always hear about these symptoms, is going to be frequency, so they have to pee frequently. Dribbling, where they have like this dripping from their penis, from their urethra. Nocturia, remember this is getting up a lot at night. And then dysuria, they may have painful urination. One of the big ones too is that they have this urgency, but then this inability to empty their bladder. So they feel like, oh my gosh, I gotta go right now, and then they only go like a teeny bit. So unable to empty bladder. Let's see. So the way that we confirm this, it's usually seen in men like ages 51 to 60, but I think they start screening at 40. And the confirmation is with a digital rectal exam. And what this means is they put their finger, that's the digital part, in their rectum, and they can actually palpate the prostate if it's enlarged like this. So DRE stands for digital rectal exam. There is a lab value called a PSA, a prostate-specific antigen, and that is elevated. But it's also elevated in cancer as well. So we wouldn't know that whether it was cancer or BPH with just a PSA. So usually they'll have to check and see if it is, what is the word that I'm looking for? If it is cancer. But I'm trying to see the survival rate for prostate cancer when they're treated quickly is good. Like they can target it very specifically. So sometimes we use what's just called watchful waiting and just see, is it getting bigger? Is it causing more problems? So the biggest thing that they do to diagnose it is this digital rectal exam. And they usually want them to do it every year. We can do some medications like Proscar or Flomax. But then there is a, before we go to meds, they actually count watchful waiting as a form of treatment. Watchful waiting. Then meds. They may do something called a TERP, which I think is on the next slide. No, I keep thinking things are coming, but they're not. Okay. So they have something called a TURP, which is transurethral resection of the prostate. So you go up into the urethra and shave off part of the prostate that is obstructing the flow of urine. After this procedure, the patient will be hospitalized. They'll have a 3-way Foley inserted into their urethra. One tube is going into the bladder, flushing it with tons and tons of fluid. You'll have these giant 3-liter bags of fluid going into the bladder really fast, and then one tube is for draining the bladder and that fluid, and then the other tube is for the balloon. So there's going to be 3 ports on this Foley after a TURP. And you will want to see pink tinged urine. That's a good sign that it's flushing out the bladder really well. You do not want to see clots. You don't want to see bright red blood. The patient is going to feel like they have to pee. They've got a Foley in, but they're going to, especially if they're confused, they're going to constantly tell you, like, I gotta go pee, I gotta go pee. That is normal for them to feel that way because the pressure from the balloon. And so you'll just have to keep reminding them that. Some of the education is to tell them that, so that they will have a feeling that they need to void. Let me put my education up here. Education will feel the need to void due to the pressure of the balloon. Their PSA level may be elevated for weeks after surgery. So remember that level that's elevated in cancer and BPH? Well, after this test, they need to know that that level could be elevated for weeks. After surgery. And then they have to avoid decongestants. Remember, we talked about some of the things that are going to not help our BPH patients. So decongestants can cause the body to retain urine. Well, we just took the patient through this whole surgery to keep them from retaining urine. So we do not want... The decongestants can cause an elevation in blood pressure, and we don't want them to have that because it can obstruct things more. So no decongestants. Okay, erectile dysfunction. This is, yes, I think many of you know what this is, but we'll go ahead and write it. Inability to achieve or maintain an erection. An erection for successful intercourse, or I guess I should just say just as for sexual intercourse. I guess I put the word successful in there. Intercourse. So treatment, there's a lot of things that we can do. Probably the one that you know of most is Viagra. The generic name is sildenafil. There's something called alprostadil pellets. We can do a vacuum device, an intracavernosal injection. You'll see these are getting more invasive as we go, so it's, depending on how bad the patient wants, or how aggressive they want us to be with their treatment. Sometimes this is something they won't even tell us about, but erectile dysfunction is something that can result after prostate issues. So it's something that we would discuss with our previous patient that we just talked about with BPH. There's a vacuum device, surgery, but then also psychosocial treatments. So there's going to be a lot of mental aspects related to this because it impacts so much in their life, and it's difficult to talk about. Let's see. Oh, before we start any meds for this patient, we have to do a cardiac workup. So the erection occurs because of blood flow going to the penis and holding it erect so it can penetrate the vagina. But if there's a problem with having an erection, there could be a problem with their heart. And so before we start them on any of these meds, we need to check out their heart. But also, some of these meds have the potential to drop their blood pressure severely. So we need to make sure we do a thorough assessment of all of that. Testicular trauma. So what do you think testicular trauma is, and when do you think it might happen? Just think about that for just a second. So usually from sports injuries or penetrating trauma, like a car accident, or, I guess some kind of violent act if someone intentionally injures that area. Sports injuries or penetrating trauma. The treatment. So depending on how bad it is, we could just do NSAIDs, and that might be enough just to treat the pain. NSAIDs. Compression. In terms of compression, we don't want it to be too tight, but we don't want to allow the testicles to be too loose also, because then it could be could allow for more swelling. Ice can help, and possible drains to decrease the swelling. So if you look at this, it is, well, it's, let me see. I didn't write the rest part yet. You also need to just rest. Let's see. This is our conservative treatment, and it's very similar to our like sprains and strains, our rest, ice, compression. But what I would like to say for compression is more like scrotal support. Because when I think of compression, I think of like wrapping it up really tightly, but it's more just to keep that scrotum supported. Let's see. If you do not give scrotal support, or if you treat it with heat, it can actually increase the trauma and increase the swelling. So it's very important that we do ice and scrotal support, not heat, and not avoid the support. We do not want to avoid the support, is what I'm trying to say. We absolutely want to give them scrotal support, give them ice. Alrighty, now prostate cancer. So this is very slow growing. It's often unnoticed because there's no pain. So cancer of the prostate, slow growing, and often unnoticed because it's not doesn't have associated pain. Alrighty, so what is going to be well, before I go into the treatment, we do need to talk about some risk factors. So our risk factors are our African American population, men older than 65, red meat and calcium. And a high BMI. So we want to stress the importance of a healthy weight in avoiding this. It is curable. Prostate cancer is curable even if it's metastasized. So our treatment, we're going to be doing our annual digital rectal exam. It's not really treatment, but it's listed under here. And PSA, so our PSA levels. The cutoff point for the PSA is 4 nanograms per milliliter. You do need to know this. So 4 nanograms per milliliter, that is the cutoff. So higher than 4 is not good. The actual treatment now is chemo, radiation, and cryotherapy. So that's like freeze therapy. So the outlook for prostate cancer is usually very good. It's just we've got to do these screenings because they may not know they have it for a long time. All right, so now for testicular cancer, we've got obviously cancer of the testicles, and it's also painless. This is why it's really important to do those testicular self-exams. So a painless mass, swelling, hardness of the scrotum, and possibly dull abdominal pain. We'll do an ultrasound, so an ultrasound of the testicles and a physical assessment to diagnose it. We want to teach the patient about a testicular self-exam, and we may do chemo, radiation, or they may actually just remove the testicle. So this next one we'll go through kind of fast. It's very rare, but it could happen where there's male breast cancer. So normal growth of male breast tissue. And the treatment is going to be chemo, radiation, surgery, and possibly hormone therapy. Okay, and the next one is bladder cancer. This is actually fairly common when talking about types of cancers. Smoking is the main cause. So I'm just going to write this: cancer of the bladder. It's the 4th most common cancer. There's a tumor in the bladder itself attributed to some genetic changes in the target cells. We don't know why that happens, but we do know that there is a link with smoking. So the treatment, we just have to remove the tumor, but it's often removed through something called laser or something called fulguration, which is laser or electrical current. I'm going to write that down. Excision of the tumor through laser or electrical current. Oh no, there it goes. Okay. And the term is called fulguration. They can also do intravesical chemotherapy. So basically, they're instilling medication right into the bladder via a catheter. Chemo. The medications kill the actively growing cancer cells. After we instill it, it can be left in the bladder for a period of time, and then we can drain it, or they can just pee it out. But as with any cancer, early detection is key. So we want to make sure our patients are getting their regular checkups, especially if they have this cancer or any kind of cancer in the family. All right, so moving on to urinary tract infections. This is an infection anywhere in the urinary tract. There's a lot of causes. Let me go ahead and see if I can fit them. So causes, some of them are related to sexual activity. Diabetes. Diabetes can place patients at risk for a lot of infections. Poor hygiene. Some of our patients don't know that you're supposed to wipe, our female patients wipe front to back. It could be because of an estrogen deficiency. Recent catheterization, so a catheter. And any foreign objects like a kidney stone. The symptoms will depend on like where it is in the urinary system. If it's up by the kidneys, they will always say flank pain. You will see that so often. Flank pain if you've got a pyelonephritis, where you've got the kidneys that are infected themselves. Cystitis is an inflammation of the bladder, so you would have, this pain in your actual bladder. Dysuria, let me see if I can fit all this here. Dysuria, so painful urination. Dysuria, urinating small amounts. Often you have that frequency, that urgency. Let me rewrite this. Urinating small amounts. Suprapubic pain, so pain right above your pubic bone. Frequency, urgency. They may have hematuria. Frequency, urgency, maybe hematuria. Can't quite fit that. Hematuria. If it's systemic, they might have a fever or nausea and vomiting, and that would mean they need to go to the hospital. You can get septic from a urinary tract infection. That's whenever, again, you would see a high heart rate and a low blood pressure and probably a fever. So that would be some of the complications, would be sepsis. And then pyelonephritis is a really bad complication because the kidney itself, your kidneys do a lot of jobs. So if those are getting infected and inflamed, it's going to impact more than just your urinary tract. So with treatment, first we've got to diagnose it with a UA. Is the urine cloudy? Is it bloody? Is there white blood cells? And then the medications. Let me write this to diagnose. And then medications would be, we would need antibiotics. But what are we going to do before we start them on antibiotics? We have to make sure that we get send our culture. Okay, the next one is hopefully something you talked about in 5th semester, symptoms of incontinence. So basically, you are unable to control your loss of urine, so involuntary loss of urine. So normally you're supposed to be able to, decide whenever you're going to go pee, you go to the bathroom and are able to use that sphincter, but some people lose urine without intending to. So there's not really a good treatment. There's some non-surgical things that we can do to help prevent incontinence. So Kegel exercises, which you may have learned if you've ever had a baby. Kegels, there's a pessary device that goes into the vagina that helps. Pessary device. You can do catheterization, clean intermittent catheterization, so you're emptying your bladder on a schedule so that it's less likely that you're going to lose urine unexpectedly. But there is a surgical, I should have wrote this under here, under non-surgical. Surgical is putting a, what is it called? It's a suburethral sling. This is surgical, suburethral sling. So they actually put a sling in under your urethra to give it more support so that the bladder doesn't just spill out. The urine doesn't just spill out. Sometimes they can give meds like, what am I trying to say? Those meds for overactive bladders, sometimes that can help. But trying these non-surgical measures are usually the first thing that they're going to try. The Kegel exercises, the pessary device, or clean intermittent catheterization. Just before we move on, though, I need to remind you guys that this is not a normal part of aging. There's all these things that people say, oh, it's just because I'm getting older, but this is not considered a normal part of aging. The risks are due to childbirth, so having kids, smoking, and obesity. So not because of aging, childbirth, smoking, and obesity. Alrighty, so now genital herpes. Let's see. The important thing to know about herpes is that it presents with vesicles. Your STIs, your sexually transmitted infections, will all look a little bit different, but this is the one that has vesicles. Let's see, what else do I need to tell you? These vesicles are usually painful and itchy. So if your patient has genital herpes and tells you that they're painful and itchy, that's you will want to, let them know that that's a normal finding. There's probably something we can do to make them more comfortable, but we do not need to call the doctor. When when the patient has genital herpes, we're going to give them the antiviral acyclovir. This is given prior to an outbreak. If they already have the virus and they know that it's about to erupt, we can take acyclovir to help with that, or once they're diagnosed, we can give it to lessen the symptoms. So this is an antiviral, and it's given for a lot of different things, not just genital herpes. So if you see someone who's on acyclovir, they could have the cold sore herpes on their mouth, or a different kind of virus in that family. So you don't just automatically assume that it means they have genital herpes. So there's something called a prodromal stage. This term, you may have heard it. I'm trying to think of when else. We talk about it with seizures and stuff. But the term prodromal is basically whenever, prodromal phase is when they have these symptoms where they know the vesicles or the lesions are about to erupt. So we want to promptly start medication during that time to help ease that stage. Promptly start medication during that prodromal phase, and that will help decrease the severity and the duration of the outbreak. So Under the symptoms, I guess I'll have to put this over here, these painful and itchy lesions on the genitals. Painful and itchy lesions is what I wrote. Some things that can help are warm salt baths. That helps with the pain and itching. Patients who experience 6 or more outbreaks in a year are going to need suppressive therapy. So they may need to go on immunosuppressants if they're having 6 or more outbreaks in a year. Some other symptoms besides the vesicles, they might have a fever, they might have a headache, they're going to have that itching, burning, they may have myalgias, which is muscle aches, swollen lymph nodes, and flu-like symptoms. There is a table in your book, table 67.3, that shows these symptoms. And then the risks. So the risks are, I just had them, but they are multiple sexual partners, multiple sex partners. Let me see. Well, I'm not seeing my my list of these, so we'll just go on, but just know that it is transmitted sexually, and so usually somebody who's not monogamous, who doesn't just have one partner, is more at risk for any STI. And I'll come back to this if I can't see anything else, but I believe it's not on here because we didn't need to discuss it. The big thing about the herpes is that it's vesicles, which is different from the other ones. And painful and itchy lesions does not warrant a call to the doctor. During the prodromal phase, we want to promptly start the medication to decrease the duration and severity. And if they have 6 outbreaks in a year, we need to start suppressive therapy. All right, so now for gonorrhea. So gonorrhea is another STI. It's actually bacterial. Bacterial STI, whereas herpes was a virus. It's presented with vaginal discharge, dysuria. So here's another disease that has this symptom, and intermenstrual bleeding. So bleeding even when you're not on your period. So this is really important, guys, because if you see a description of herpes, it will talk about the vesicles. If you hear about gonorrhea, it's going to talk about these changes. The causes would be this certain bacteria, Neisseria gonorrhoeae. I'm not sure I know how to say it. Bacterium Neisseria that one. With males, they also have dysuria. So I guess the ones I wrote up here are for the female. Men will have dysuria. They will also have urethral discharge, not vaginal discharge. And it's a lot. It says copious amounts of urethral discharge, and it's purulent. They'll have rectal pain and bleeding. So once again, notice there are no vesicles. If a mom has gonorrhea and gives birth to a baby, they will use these eye drops, a antibacterial eye drop, to reduce the chance of blindness. Okay, we're almost done, guys. I know this has been really long. So secondary syphilis, we've got it's a complex chronic infection. It could infect every organ of the body, but what we usually see is a rash or mucous membrane lesions. So, my voice almost made it the whole way through. Oh yes, so not vesicles. It's not vaginal or urethral discharge. This is a rash. It could be macular, papular, or pustular. Macular, papular, pustular rash. The treatment is going to be penicillin. If somebody is allergic to penicillin, they could do doxycycline, but doxycycline may not be as effective. So penicillin is always our first choice. The macupapular rash could be on their palms. So let me write this here. So rash on palms, soles, buttocks, and upper thighs. So the palms of your hands, the soles of your feet, the buttocks, and upper thighs. Very uncomfortable. So penicillin first, unless they cannot have it, then we will try doxycycline. Alrighty, so the very last one, excuse me, I need to cough. Okay. Chlamydia. What is chlamydia? So here's another STI, a urogenital infection. It primarily infects the urethra and the cervix. With males, they will also have dysuria, urethral discharge, proctitis, and rectal discharge as well. Females will have dysuria, and then they'll have dyspareunia. Let me see if I'm not sure how to pronounce this one, but this is painful intercourse. Abnormal abnormal vaginal bleeding. Vaginal discharge and cervical abnormalities. Vaginal discharge, cervical abnormalities. So again, this is different from the others. It's not vesicles. It's not a rash. It does have some similar symptoms to gonorrhea, like with the discharge, but it's not a rash or vesicles. And then let me just take a peek at my notes to make sure there wasn't anything else I wanted to say. Okay, that will be it. And please let me know if you have any questions on this information.